Um, Picture this for a second. It's 2009. You're in the dust of Kono State, Nigeria, and public health monitors have just discovered this really terrifying reality on the ground.
Right, because an outbreak is starting.
Exactly. It's a sudden outbreak of a vaccine-preventable disease.
Mm.
But it wasn't just the disease itself that was the problem. It was that the local community had absolutely zero infrastructure to fight back.
None at all.
Yeah, no diagnostic tools, no specialized training, and just no local workforce equipped to respond. So they were completely exposed to what the official records call a silent threat.
Which is, I mean, that's really the ultimate public health puzzle, right? Because historically, the global reflex to that kind of situation has just been parachute aid.
Oh, totally. The crisis hits, and
Because
then,
international agencies fly in, right?
yeah,
They deliver all these emergency supplies, they hand out the vaccines, and then they just leave once the immediate fire is put out.
leaving the underlying fragility completely untouched.
Exactly. The next time a crisis hits, that community is just as vulnerable as they were before.
Which is exactly why today's deep dive is tracing such a, well, a really fascinating evolution. We are looking at how you take a community from that state of extreme vulnerability and permanently rewire it for lasting wellness.
It's a massive shift in thinking.
It is. And we've got a really detailed stack of sources today that follow one very specific trajectory. We're starting with the raw field experiences and the 17-plus year curriculum vitae of an epidemiologist, Dr. Gift Aniyom.
Right, starting from the very grassroots level.
Yeah, and then we're following that thread all the way up to the massive organizational proposals of the Gift Aniyom Foundation, or GAF. And finally, capping it off with their brand new May 2026 Polisync AI framework.
Which is just wild to see the progression.
It really is. So whether you are, tracking global health policy, studying how to scale grassroots organizations, or just looking at the integration of AI and humanitarian logistics, this deep dive is basically a masterclass in building resilience from the ground up.
Yeah, and to really understand the foundation's DNA, I think we have to start with that field work you mentioned.
The early days.
Right. The sources show Dr. Aniyom's early groundwork around 2008 and 2009. We see roles as a UNICEF and NYSC IVAID's peer educator trainer.
And just for context, NYSC is Nigeria's National Youth Service Corps. It's a mandatory postgraduate program that often sends young professionals out into rural areas.
Exactly. And at the same time, we see Dr. Aniyom acting as a WHO independent monitor for immunizations across Kano, Rivers, and Cross River states.
Which, being an independent monitor, that means you aren't just looking at a spreadsheet in an air-conditioned boardroom.
No, you are out there.
Yeah. You're physically verifying that cold chain vaccines are actually making it into the arms of people in these marginalized, hard-to-reach areas.
And when you look at the trajectory of global health interventions back then, it feels a lot like trying to fix a sinking boat with a bucket.
Just bailing water.
Right. Handing out vaccines during a crisis is bailing water. It keeps the boat afloat for one more day, sure. But at a certain point, you have to teach the crew how to patch the hull. You have to build a stronger ship.
And the sources suggest there was this growing realization that the entire system needed a permanent upgrade.
Yeah, and that realization really compounds over a decade and a half of just escalating, relentless frontline work.
Yeah.
The CV details Dr. Aniyom serving as an epidemiologist for GeoWARN.
The Global Outbreak Alert and Response Network.
Exactly, working the Lake Chad Basin yellow fever outbreak. And then we see these really heavy-duty roles managing surveillance during cholera and Ebola outbreaks, serving as a COVID-19 surveillance supervisor, and even operating as a principal technical officer at the Africa CDC headquarters in Addis Ababa.
That is a serious resume.
Mm-hmm.
And when you coordinate outbreak responses across national borders year after year like that, a really clear pattern has to emerge, right?
No, unfailingly. You see the exact same systemic failures repeating themselves over and over.
Because the local capacity just isn't there.
Right. You realize that a top-down, centralized response is always going to arrive a step too late. I mean, a centralized government agency in a capital city cannot manage the minute-by-minute logistics of a localized outbreak hundreds of miles away.
It's just physically impossible.
Yeah, so true. Enduring resilience requires local empowerment. The people who actually live in the village need to be the ones managing the data, running the cold chain logistics, and communicating the health risks to their neighbors.
And that structural philosophy is what culminates in a massive turning point in our sources. May 23, 2023.
The official launch.
Right. That's the date the Gift Aniyom Foundation is officially incorporated under CCAC registration number 6986899. We see this formal shift from, an individual's vision out in the field to an institutional engine.
An engine that's completely designed to scale that concept of local empowerment.
Exactly. And the documents outline the Foundation's core operating blueprint for actually achieving this, which they call the Emergency Ready Primary Healthcare Framework, or ERPHC.
Yeah, and this is where it gets really interesting, because it moves the foundation from the theory of resilience into the actual mechanics of it. It's built on 4 deeply integrated pillars: connect, detect, protect, and treat.
Looking at these 4 pillars, it honestly reminds me of a highly localized, specialized fire department model.
Oh, that's a good analogy. How so?
Well, Connect is your community dispatch system. Detect represents the smoke alarms. Protect is the building codes and the sprinkler systems. And then Treat is the actual medics arriving on the scene.
I like that. That maps perfectly. Let's
But
actually dig into the functional mechanics of those pillars, starting with connect.
yeah, let's do it.
So connect focuses heavily on risk communication and community engagement, RCCE.
Okay, so what does that look like in practice?
Well, in practice, it means establishing two-way communication channels. Because think about it, if a community doesn't trust the source of the information, they will completely reject a vaccine.
Regardless of how effective it is.
Exactly. So Connect builds digital and analog feedback mechanisms where communities can actually access health data, express their concerns, or even report early symptoms directly to local workers.
Which perfectly sets up the Detect pillar, the smoke alarms.
Right.
The technical proposals define this as interoperable digital platforms and integrated health information systems. And, making systems interoperable just means ensuring the data collected on a tablet in some rural clinic can actually be read by the National Disease Surveillance Database.
Which is huge. It establishes early warning systems, rapid sample collection, transport protocols. I mean, you cannot fight an invisible enemy if you don't know its exact coordinates.
Right. And then following detection is the Protect pillar. This is where we see infection prevention and control, or IPC.
Yeah, IPC is critical. This involves establishing rigorous hygiene protocols right in the local clinics, so the clinic itself doesn't become the epicenter of the outbreak.
Which happens way too often.
Way too often. It also covers the deployment of vaccines, and it tracks antimicrobial resistance, mapping out where common pathogens are just no longer responding to standard antibiotics.
Wow.
And fundamentally, it includes robust WAR-ASH services, water, sanitation, and hygiene, because you simply cannot protect a community from waterborne diseases like cholera without engineering access to clean water.
You just can't. And finally, we have Treat. Now, this goes way beyond just managing cases of the specific hazard, like isolating and treating Mpox patients.
It's broader than that.
Much broader. The sources strongly emphasize the continuity of essential care, because during a major outbreak, the collateral damage to the rest of the healthcare system can be catastrophic.
Oh, absolutely. People still need routine maternal health care. They still need their diabetes medication.
Exactly. So the Treat pillar ensures that resilient referral pathways remain open, so the entire local health system doesn't just collapse under the weight of one specific disease.
But the most crucial element of this whole ERPHC blueprint is who actually operates it.
The local workforce.
Right. The technical proposals detail a really specific demographic targeting strategy. GAF specifically recruits young people, aged 18 to 35.
Okay.
And furthermore, they mandate that at least 51% of these recruits must be women, and at least 4% must be persons with disabilities.
I really want to pause on that 4% mandate because it's such a brilliant structural decision.
It really is.
Because a person with a disability intuitively understands the specific physical, logistical, or even social barriers that their peers face when trying to access a local clinic.
Exactly. They can map out accessibility flaws in a community's health response that able-bodied planners frequently just completely overlook.
It essentially transforms what could just be a demographic statistic into a massive strategic advantage for reaching marginalized populations.
Spot on. And GAF doesn't simply hand these recruits a textbook and say good luck.
Right, they use what the proposals call a blended skilling approach.
Yeah, during these structured 6-month paid internships, and blended skilling basically means combining traditional face-to-face workshops with mobile-friendly digital modules.
Using platforms like Yoma, right, the youth agency marketplace.
That's the one. It allows recruits to access training on things like electronic immunization registers or data analysis, and it's heavily optimized for low-bandwidth environments.
So after 3 to 4 months of this pre-placement training, they deploy these young workers into public health institutes local NGOs, and primary healthcare centers to run those connect, detect, protect, and treat pillars.
They are literally embedding the operational capacity directly into the community's youth.
But a framework is really only as good as its execution.
True.
Let's look at the actual outcomes, because the scale detailed in these organizational profiles is honestly immense for a foundation that was only formalized in 2023.
It is staggering. Under their initiative to empower the frontline, GAF has trained more than 20,000 health workers.
20,000.
Yes, covering immunization officers, surveillance experts, and data analysts across all 55 African member states.
That is massive. And we also see massive clinical applications in the sources. In Nigeria, GAF supervised teams that provided HIV counseling and testing to 100,000 people.
And that wasn't just, dropping off testing kits in a box.
Right. Supervising 20 teams of 6 people across 11 local government areas means really mapping the social geography. It means utilizing peer educators to overcome local stigmas, ensuring every single individual receive their results, and then formally linking them to continued antiretroviral treatment.
It's an end-to-end clinical pathway.
Yeah.
We also see the Protect pillar applied to physical infrastructure. Based on extensive field research, GAF implemented climate-resilient wash facilities in 40 primary schools across the Akwa Ibom and Cross River states in Nigeria.
Climate resilient meaning?
Meaning engineering latrines that are elevated to prevent flooding and contamination during monsoon seasons.
Oh, okay.
And installing solar-powered boreholes so schools have safe drinking water even if the local electrical grid completely fails.
I mean, coordinating 20,000 workers across 55 sovereign states, executing 100,000 HIV tests, and engineering flood-proof infrastructure. That is a logistical mountain.
It's a huge undertaking.
If GAF were trying to build its own fleet of supply trucks and centralized management hubs to do all of this, they would just collapse under their own weight.
Absolutely, they would.
The sources call them a nexus in the public health space. It almost makes it sound like they operate as the ultimate switchboard